It's time for a Q&A. So we call back the three doctors for live Q&A. Dr. Joanne Robles, Dr. Lynne Lucena, and our dear moderator, Dr. Geraldine Jose for the live Q&A.
First and foremost, we would like to thank our speakers and of course our audience who sent their questions for our speakers to answer. We'll try our best to have most of your questions answered, but we have only 15 minutes left. Some questions, dear speakers, may be answered by just yes or no, so that we'll cover as much as we can. So let's go first with our first question for Dr. Lucena. Does the history of the mechanism of the injury essential in diagnosing the type of TBI?
Yeah, a lot of times also it affects the mechanism of injury. For example, you have a patient on a two-wheeled vehicle versus a patient inside a car. So that will most probably, the patient in a motorcycle would most probably have a more severe traumatic brain injury versus a patient who rides inside a car.
Okay. And number two question, is a cervical X-ray a requirement for all traumatic brain injured patients?
Yeah, usually when the patient comes in, actually at the emergency department, meaning at the site of injury, patients should already be placed on a cervical collar. That's the ideal. It should be a Philadelphia collar, not just a soft collar or anything, because a lot of these patients would have concomitant cervical injury, and sometimes the transport even worsens it. So a cervical epilateral X-ray is also very crucial to detect that there is no missed injury in the cervical region.
Okay, thank you. And number three, do we expect an increase in ICP in conditions of diffuse axonal injury?
Yeah. Because diffuse axonal injury patients have several grades. Okay, so there's mild, moderate, and severe. So these patients who have more severe type of diffuse axonal injury usually has higher intracranial pressure, and usually are in GCS they present more with severe traumatic brain injury.
Okay, the last question. How quick does the hypertonic saline solution like Totilac take effect to reduce brain swelling?
Usually, Totilac has been used as a resuscitative fluid. So the effect usually is also immediate and comparable to mannitol.
Okay, thank you very much, Dr. Lucena. Let's now go to Dr. Robles. So thank you for that extensive lecture. We all learned from both of you. So what are the most common organ systems, organ dysfunctions that you expect which are involved in traumatic brain injury?
Is this for me, Doctora?
Yes,
or
it's for you.
Okay. Okay. So usually even preoperatively, because as mentioned by Dr. Lucena, you can have polytrauma. They don't come to you with just, the head being the problem, especially if it's a motor vehicular accident, which is quite common in the Philippines. So what happens is they come to you with abdominal injury, they come to you with cardiac injuries, pulmonary problems become an issue because contusion hematomas can occur. So usually these patients, even if they are awake, eventually do require ventilatory support because of a significant pulmonary contusion. Or some of them, as previously mentioned by Dr. Lucena, may go into pulmonary edema, which is not solely from the injury itself, but actually could be also neurogenic in nature. So that can also be one of the subsequent injuries. And of course, during the course of care, if they have multiple injuries, rhabdomyolysis can induce a lot of acute kidney injury. Even subsequent use of osmotherapy can induce acute kidney injury. So I think that the advantage there of coming into an ICU with multidisciplinary care services can actually be very useful because you have a team that's going to anticipate a multi-organ dysfunction for these patients, because it's not just about the acute injury, but also about the secondary injury, which can be from head to toe. So nutrition becomes a problem. Dr. Lucena already elucidated that. So the inflammatory state can be quite extensive, and it's not just confined to the brain alone. And this is not just for traumatic brain injury patients, but for all neurocritically ill patients that come into the ICU.
Okay, thank you for that. The second question is central fever something that you expect in a TBI patient? And how do you differentiate it from an infectious nature, once the patient comes in the neuro ICU?
Okay. Generally, you wouldn't expect it to be central in nature if the patient is awake. The extent of the neurological injury usually translates to the response of your brain and the dysregulation of your hypothalamic axis. So that's where the central fever comes in. So if your patient is awake, GCS 13, 14, even more than 10, getting a central fever might not be likely. So if you get a fever in that particular GCS range, then chances are it's from another cause. If they do develop fever and you think that it's central in nature, then it may be because there's also a concomitant expansion in the hematoma, nag-decrease na yung GCS scores nila, or you have an injury to the hypopituitary axis or the hypothalamic axis. So pwedeng doon nanggagaling. But in patients with high degree of injury, like for example, subarachnoid hemorrhage, even if they have low grades, they may have a form of fever. And this is because you induce what is called paroxysmal sympathetic hyperactivity. So their brain just goes crazy. So pwede magkaroon sila ng taas ng blood pressure, magkaroon ng recurrent seizures or motor symptoms. They can go into severe tachycardia, and they can go into fever spikes. So the fever spikes in those kinds of patients might not be from a peripheral source of fever, but actually from the subarachnoid hemorrhage injury itself. So it is a form of central fever, which will need to be addressed in a completely different manner than if you had a peripheral source of fever or an external source of fever. So working up for an infection is always of value, especially if your patient is intubated, or if you have a tube in or a Foley catheter in, or if you have multiple lines with evidence of phlebitis. So if there's no evidence of peripheral sources and your patient is in a severe injury, or a neurological injury is severe, then you might have to consider that it's central in nature, and higher ang degrees or mas mataas ang mga temperatures nila, and it's far harder to control.
Okay, last question. We really are running short of time, but the last question. Mannitol versus hypertonic saline, which is your choice, and how do you give your hypertonic saline?
I'm a fan of hypertonic saline. I have not been giving mannitol for a really long time unless I don't have immediate access to hypertonic saline. If we go back to the CPP equals MAP minus ICP that Dr. Lucena and I have been for the past 2 hours been reiterating, you really need to maximize the MAP and the CPP if you cannot monitor the ICP. Your presumption there, if your patient is not awake and you have intracranial neuroimaging evidence of edema and your patient has a blown out pupil, then definitely may ICP problem yan. So which means you need to ensure mas mataas yung mean arterial pressure mo so you can get your CPP. My problem with mannitol is that if I give 100 mLs of mannitol, hindi ko mapipredict just how much they will dump urine. Pwedeng 1 liter ang i-dump niya na urine if the kidneys are very responsive to osmotherapy, as compared to another patient who will dump out only 50 ml of urine if I give the same amount of mannitol. the thing about and also because it's osmotic diuresis, the osmotic drag can induce a significant amount of kidney injury. This is not an absolute statement. It will depend on the kind of patient you have. Some patients respond better to mannitol, while others respond to hypertonic saline. So you can combine both. Now with hypertonic saline, I find that you are able to give, like Dr. Lucena said, it's a resuscitative fluid. So you are able to give not just the volume that you need to raise the MAP, but you're also able to give the osmotic effect of raising the sodium levels. And there are other rheologic effects of hypertonic saline, just like mannitol, which can be very useful. They decrease blood viscosity, they improve the rheology of your RBCs and your platelets. So they have a lot of advantages. So the question will be, are the kidneys functioning? Are you able to access your hypertonic right away? Do you need to combine both? Does your patient need both? Is the patient still responding to mannitol? Should I move to hypertonic? So generally, when the Neurocritical Care Society came out with their recommendations for osmotherapy across the board, most of the recommendations were really more for hypertonic than they were for mannitol. But that does not discount the fact that you can still use mannitol. It's just about how long you can use it, because the reflection coefficient of mannitol is 0.9 as compared to hypertonic saline or sodium, which is 1. So even if they both have neurological injuries or they're given to patients with neurological injuries, mas madali na magkakaroon ng pagtawid ang mannitol as compared to saline, which means that given beyond 5 days, mas marami na, 5 to 7 days, mas marami ng osmoles of mannitol na nandoon sa brain side rather than the blood side. So hindi na siya magiging kasing effective as compared to when you first gave it. That's why over time hindi na siya nag-work and you have to slowly taper it off. So having said all of that, obviously I am more of a fan of hypertonic saline, and this can come in different forms. So I use 2% if I don't have a central line. Hypertonic sodium lactate can be given through a peripheral line because the lactate content can also minimize the injury to the peripheral blood vessel. Ideally, if you're giving it for a sustained period of time, you would want a central access. But you can give lower volumes and lower concentrations of hypertonic saline through a peripheral line if you don't have immediate access to a central line. But yes, a central access would be best, even for mannitol.
Thank you for all that. Of course, not without saying that we have to properly monitor serum sodium concentration also periodically while the patient is on hypertonic saline. Because
Yes, yes.
it will also come with its own risks if we're not be able to maintain the serum sodium within the acceptable range of around 145 to 155, right?
Yes, yes.
All right, so thank you very much. In summary, it just goes to show that a comprehensive approach to a traumatic brain injured patient is very important.